Okay, I'm going to talk to you guys about tracheostomy, and I'm going to talk about firstly the indications for tracheostomy, which are obviously divided into airway and breathing. Breathing would be a permanent lack of airway, so patients had a laryngectomy, or they've got problems with recurrent secretions and problems with clearance, or you think they're going to have a sustained inability to protect their airway. So I'm thinking about neuro patients or patients with neuromuscular disorders. And then breathing problems would be a permanent lack of ventilatory drive. Again, that would be a neuro patient. Likely prolonged ventilation and weaning. So again, that's going to be patients with neuromuscular disorders, neurological injuries, weakness, the elderly. And again, for secretion management, because they're likely to retain their secretions and develop VAP. Okay, so contraindications to performing a tracheostomy. So contraindications should be divided into absolute and relative. Absolute contraindications would be a severe bleeding disorder and a physiologically unstable patient, patient refusal, overlying infection and overlying artery. And relative contraindications would be a known difficult airway, so perhaps you would want to reconsider whether or not it's worth changing what you've already got in. Difficult landmarks, an unstable C-spine, and a coagulopathy, a moderate coagulopathy, and borderline respiratory function. So I've changed this. It's not divided into absolute and relative, but into the lurid crab. So difficult landmarks being L, unstable patient being U, patient refusal being R, overlying infection being I, difficult airway is D, unstable C-spine is C, borderline respiratory function is R, overlying artery is A, and bleeding disorder is B. Okay, so right, let's go through those just one more time. So L is landmarks, U is unstable, R is refusal, I is infection, D is difficult airway, C is C-spine, R is respiratory insufficiency, A is airway, difficult, and B is bleeding. So then once you do get on with putting in the tracheostomy, there are some complications you need to watch out for, which are during insertion, early complications and late complications. During insertion you could lose the airway, patient will desaturate, they usually will. There'll be bleeding, minor or major. They may aspirate the blood, and then you can cause damage. Posterior tracheal wall, surgical emphysema, pneumothorax, cricoid cartilage or tracheal rings. Early complications would be accidental removal, which is a problem because you can't put it back in. Blockage of the tube, late bleeding and infection. And then very late complications would be tracheal stenosis, tracheomalacia, tethering and vocal cord palsy. So, well, the peri-procedural complications are going to be bleeding, aspiration, loss of airway, local damage, and desaturation. And then this is going to be bleeding, again, accidental removal, I is infection, and L is not sure. V is vocal cords, T is tracheomalacia, and tethering and stenosis. Okay. There's no evidence to say that doing an early tracheostomy is better than doing a late tracheostomy, and very interestingly in TrackMan they found that when they looked at 900 patients they allocated to early and late tracheostomy, they didn't find any difference in mortality or morbidity but what they did find is that 45% of those in the late group didn't actually need a tracheostomy. 2014 meta-analysis showed that shorter ICU stay with early trachea showed a shorter ICU stay with early trachea, but no mortality difference. Just because I got distracted, just to say again, so in the TrackMan study, the late group, 45% of those allocated to late tracheostomy did not get a tracheostomy. So I think that does say a lot. Tracheal anatomy is bounded superiorly by the cricoid cartilage, and it's attached to it by the tracheotracheal membrane. It's got skin, fat, thyroid, strap muscles and fascia overlying it. It's esophagus posteriorly. Carotid sheath containing the jugular, the carotid artery and the vagus laterally, posterolaterally, the recurrent laryngeal nerve posterolaterally, and often it has an anterior jugular vein that comes across, and that can be a cause of bleeding. That's a picture. So this is the big thyroid cartilage here, and then the cricoid cartilage, which is around here, and then this is the membrane, and then that's probably the first ring here, and overlying maybe the second and third is the isthmus of the thyroid. This is the common carotid, this is the right brachiocephalic, this is the left subclavian, obviously this is the trachea here. Inner tube should be changed regularly and cleaned regularly, and entire tube should be changed every 30 days. Just quickly, you should consent and explain the procedure to the patient, prepare all your equipment and make a plan for failure. Patients should be nilled by mouth for 6 hours. You need to establish monitoring, check the equipment, put them in position, I do an exchange catheter technique, do a railroad swap it, inflate the cuff and connect the ventilator and check and confirm that you're ventilating. Check the cuff pressure is less than 25 centimeters of water, and document everything. Weaning. A trachea should be removed as soon as possible. There is no documented best practice for weaning. The unit we use is to commence with spontaneous breathing trials and then increase the length and the frequency of those trials. The risk of removal is that the patient could aspirate, they could obstruct, and it's going to be difficult to get a new airway in. You may cause injury as you pull it out. They may fail and you need to put it back in, and they may not be able to clear the sputum. In general, when you think about taking people off ventilators and off tracheostomies, you think about reversal of original pathology. You should think about neuromuscular blockade or neuromuscular function, and you should think about any procedures planned.